I'll be able to share my screen in a minute.
Yeah, you go down. Yeah, good.
Okay, can you see my slides now?
Yeah, but you can start the slide for now. Yeah, from beginning. Yeah, good.
Okay, is that okay? Can you see my slides?
Just I think, yeah, we can see.
Okay, so good morning all. Thank you very much for this opportunity. Thank you very much, Dr. Mishra, for this opportunity to present in a cardiac diagnosis. When we look at it's very cold here in the UK. It's nearly 11 o'clock in the morning. So when we go to before we go to the topic, let's look at a little bit about the history. And the picture I put here is of the Hippocrates. The Hippocrates was considered as a father of medicine. 2,500 years ago, he wrote Hippocratic Oath. We don't know whether it was written by himself or whether there were a lot of speakers, a lot of authors were involved in that. Subsequently, it got lost in the history and then eventually discovered back in 15th century by some eminent Christian scholars. They translated it into English, and it was taken as oath by many of the medical professionals subsequently. The first time it was used in 1960 in the US, where they used it in a medical school, and various versions since then developed over the period. It is important to understand this because the main essence of this Hippocratic Oath is not to cause any harm. And as a clinician, we try our best to help our patients. We try our best to give every advantage to our patients. Sometimes the risk does happen, and it is mostly like unintended risk. And that's where we have to see how we can prevent risk. So when we talk about the benefit and risk, the benefit is of the two different types. One is intentional benefit, which we are trying to achieve for our patients. This is a benefit when you try to give the medications to lower the blood sugar, so you replace the thyroid hormones or any of the endocrine hormones to give them the benefit, absence of whatever the symptoms they are developing, just to relieve those symptoms. And the unintentional benefit, this is more like a bonus point or the brownie point, which we unfortunately don't get always. But recently there was some good news in the diabetes faculty. We have seen that with SGLT2 and the GLP-1 medications, when they introduced into the field, they were more medications to reduce the blood sugar levels. But over the period, we have realized that not only they reduce the blood sugars, also reduce the weight, they give us cardiovascular benefits. So these were all the brownie points, what we got. Nobody expected them in the first place. So it was a very good actually. And it would be wonderful if we get that every then. If we get the harm, the intentional harm, nobody wants to harm anybody, a human being. We don't want to cause any harm. Obviously, as a physicians, we try every best even to avoid the unintentional harm. But is it possible to avoid the unintentional harm every time? And what it means in the modern medicine? How do we look at Hippocratic Oath? In my view, modern medicine, the unintentional harm come into the various format. So it means treating the person as their individual, not to treat their medical problems itself, but treat them as a whole, more like a holistic approach. Make sure that we don't diagnose, to make sure we don't, because of so much technology is available these days, we have to make every effort not to get lured into the technology and then try to treat all these drug charts or the observation chart, look at the individual. And when we look at it, we have to always ask the questions ourselves at whatever the benefit we are going to achieve by certain medications or certain treatment modalities, whether it is a worth of risk taking in that particular individual. And this is where we see more often the harms of this and how we can prevent that in the future. My topic A lot of eminent speakers already spoke about the how to get sugars down. Dr. Chawla mentioned about very nicely about timing range previously. I would like to take you to the other extremes of the diabetes management, which is a hypoglycemia, and it is most of the time we tend to forget about, because the most of the focus is on a hyperglycemia and try to get the blood sugars down. Even the patients want to congratulate themselves when their HbA1c is down and when they achieve that good control. But the hypoglycemia has a lot of other side effects, I would say, in the clinical practice, and some of them they surface, some of them we are not aware of it, but they come. We have to look for them, and we have to educate our patients to prevent them in the future. So the focus of my talk today is going to be on epidemiology, what we learned from the epidemiological studies. We will also look at some clinical cardiovascular outcome trials. What did they teach us about hypoglycemia and the implications of hypoglycemia in certain populations, which we see in the clinical practice. We'll also see the mechanisms of hypoglycemia, how the hypoglycemia induced cardiovascular system damage, and also, if the time permits, we'll look quickly at the approach and the management of the hypoglycemia. So as we all know, the main focus of the hypoglycemia is on the brain, because it causes cognitive dysfunction, it causes the people in a hemiparesis, and even it can cause, if it is not treated immediately, it can cause seizures, coma, and ultimately death. It can also cause falls, which eventually result into the fractures, joint dislocations, and I have seen a few of the joint driving accidents because of the hypoglycemia. Circulation side effects because of the hypoglycemia, these are also well known, where we have seen the hemodynamic changes, blood vessel inflammation, coagulation abnormalities, and that has resulted into the myocardial infarction, cardiac arrhythmias, and cardiac failure. Again, the cardiac arrhythmias, this is a most common cause in a young type 1 diabetes populations, where they have nocturnal hypoglycemia, which can cause silent cardiac arrhythmias and which can be dangerous to the health itself. So when we look at the epidemiological studies, this is a very beautiful study, which was, it is called as a global head study. This was carried out in 24 countries, and they have studied type 1 and type 2 diabetes populations to look at what is the risk of hypoglycemia in these populations. This was a study where they use actually the blood glucose diary for the patients. So patient will monitor their blood glucose, write down the blood glucose. All these patients were more than 18 years of age, and they were on insulin for nearly 12 months. Large number of populations was involved, so nearly 19,000 population of type 2 diabetes and nearly 8,000, more than 8,000 patients with type 1 diabetes were studied. What we have noticed from this study is that the hypoglycemia risk was quite severe. It was found to be nearly 47% overall risk of hypoglycemia in type 2 diabetes, while in type 1 diabetes, it was very high. It was nearly 83%. When we look at the nocturnal hypoglycemia, which now we can see on the CGM, thanks to CGM, we can review that in a patient-to-patient basis. So this was seen 16% in type 2 diabetes, while it was again very high, about 41% in type 1 diabetes. What was more alarming is on your left of the slide, if you see, no matter what your HbA1c is, you can still have a hypoglycemia. So the type 1 diabetes and type 2 diabetes, the occurrence of hypoglycemia was fairly stable. Obviously, it was more in type 1 diabetes because of the insulin effect. But even though the patients with a good control, like HbA1c of less than 7%, or patient who has got a suboptimal control, like HbA1c of more than 9%, the hypoglycemia was still very striking features. If we look at your right side, the slide which is from the which is comparing the various countries which were involved in the studies, and this is showing that the overall global risk was 2.5 per person per year of hypoglycemia, while if we look at the Southeast Asia, the risk was even higher, which was 3.4 per person per year. So what we have learned from the HAD study is that the hypoglycemia is very common, and it is widespread. It is more common in certain populations. And they also look at the prospective and retrospective analysis for this study. where they ask the patient what do they think about how many episodes of hypoglycemia they are getting on a day-to-day basis. And when they compared that with actual hypoglycemia, there was quite a discrepancy between the two. So hypoglycemia is always underestimated, not only by the clinicians, but by the patients as well. So it's very important to address that. This is a second analysis, very beautiful one. Again, look at nearly 500,000 patients, 46 studies they looked at. And again, the feature was quite striking. They have noticed hypoglycemia in 21%, which was a severe hypoglycemia. So severe hypoglycemia is the one where the patient has a severe symptoms of hypoglycemia where they cannot treat those and they need the third-party assistance, which has got a strict criteria for the driving regulations in the UK. If the patient has got more than one severe hypoglycemia in a year, in a 12-month period, then they have to inform to the DVLA. While there are, again, with heavy vehicle drivers, severe hypoglycemia should not have even a single episode. So as we can see here, the severe hypoglycemia was more common on the insulin as compared to the sulfonylureas. And interestingly, even the similar amount, like a 5% of hypoglycemia was seen in patients who were not on the sulfonylureas or the insulin. If we look at the events per person per year, again, the insulin tops the list with 1.05 and followed by sulfonylureas, which was quite negligible. So does this really matter, or do we see that in our day-to-day clinical practice? So this is another data of the incidence and trend of hypoglycemia hospitalization. This was published in Diabetes Care in 2017. Again, this was done over the period of 15 years. And what we learn here is that this is the data from England. Obviously, as you can see, there is an increasing trend of the hypoglycemia admissions. So the observed trend and estimated trend, it does match. And the populations who is a younger populations, the trend in type 1 and type 2 diabetes more or less remain the same. But the type 2 diabetes, the trend was increasing till 2009. And since then, we are doing relatively better. Actually, the trend is coming down, but still it remains higher than what it was before in 1997. And this is very alarming because now we have a better medications, we have better options for treatment of type 2 diabetes, but that is not reflecting into the hypoglycemia admissions. So we are not able to reduce these admissions to the hospital. This is another one paper which was published 5 years ago in Lancet in 2016. This was by Zakadi. And this is also showing the length of stay and mortality of hypoglycemia admission. Again, this is analysis from the England, which is a 10-year observational studies. And what you can see that the hypoglycemia rate, it starts increasing from the 40 years onwards. So as the age progresses, the hypoglycemia rate keep on increasing. And what is more alarming in this slide is that the last 80 to 89, so these are the elderly populations, there is a literally flat line. So there is no change whatsoever in hypoglycemia admissions, despite the better management strategies over the years. So this is also quite alarming. Let's look at the trend overall. So does it matter? Does it happening only in the UK, or can we see the similar picture in other part of the world? So this was a trend of severe hypoglycemia of type 2 diabetes in US. Again, they look, this is 2006 to 2013. And what we can see here is that the severe hypoglycemia still remains the problem. So again, the trend was quite increasing till 2010. Since then, it is lower down, but we are, if we compare that to 2006, there is not much change. And not surprisingly, obviously the risk of hypoglycemia remains high with insulin and sulfonylureas as compared to the other agents. This is another paper which is showing the trend of hypoglycemia as compared to the hyperglycemia. Again, it is a very large study where they look at hypoglycemia and hyperglycemia trend. And as you can clearly see, the hyperglycemia, we are better at treatment of the hyperglycemia. So this has reduced from 1999 to 2010 over the period of nearly 11 years. But the hypoglycemia trained, it is actually still quite significantly high, and it is even higher than the hyperglycemia stand. So the more and more patients are getting admitted to the hospital with the low sugars rather than the high sugars, as it is evident from this slide. Now, other things, as you can notice from this slide, is that there is a twofold higher rate of hypoglycemia in older population as compared to the younger populations. So this is a population who has got a comorbidities. They are more at risk of hypoglycemia and more at risk of dying from the hypoglycemia. This is something we need to pay close attention to. If we look at the death of hypoglycemia, so this was a very good analysis again by Zakati, published 3 years ago. And what they look at is nearly 109 countries. So this is a data of hypoglycemia death in 30 countries over the period of 14 years. And what they have noticed here is that there is a 60% increase in the hypoglycemia related death from 1999 to 2011. And again, from 2010 onwards, it is nearly a flat line. So we are not able to reduce these deaths of the hypoglycemia despite better management. So this is a more recent paper published in Diabetes Care in 2021, just this month actually, and where they look at the patients who are more than 18 years of age. These are the patients who were registered in California with a KPMC, and the outcome was studied in the form of atherosclerotic cardiovascular disease. They look at non-fatal MI, either fatal, non-fatal ischemic stroke, or death because of the cardiovascular disease. Again, it is a quite a large study. Nearly 250,000 patients were studied. Mean age was about 63.6 years. And as you can see, the hazard ratio was quite significant for the atherosclerotic cardiovascular disease. It was 3.2. And then when it was adjusted for the age, sex, and the race, it still remains quite high. It's at about 2.6. So this is a reflection of what we saw in the observational studies and the epidemiological studies. This is also reflecting in the clinical practice. When we look at the population, this was from the Diabetes Care, again, 2013 publications, look at the populations and whether these CV events and the cardiovascular mortality as well as all-cause mortality, does it actually there? You know, we always question ourselves whether it is an overestimation. And as we can see here that the hazard ratio again remains more than 2 for all-cause hospitalization as well as all-cause mortality. So let's move to the next one where we are going to look at certain cardiovascular trials, cardiovascular outcome trials, which were done in the past. And before you go there, we have to look at the DCCT and the UKPDS, what we learned from those studies. So if you look at the DCCT, actually the 65% patient from the DCCT, they had a severe hypoglycemia from the intensive arm as compared to 35% in the conventional arm. And if we look at the incidence of those severe hypoglycemia in DCCT, it was 2 to 6 times more than the conventional group. Again, more alarming from the DCCT was that the 55% of the patients had hypoglycemia during the sleep, and 43% of these were nocturnal hypoglycemia. To reflect, obviously, the DCCT was carried out in type 1 diabetes population, so we can argue that these patients were on insulin, so the risk was quite higher. But if you look at the UKPDS, which was done in the type 2 diabetes populations, UK diabetes prospective studies, the major hypoglycemia episodes was again 0.7% in a conventional group, and it increases expectedly in 1.4% in patients on glibenclamide, which is longer acting sulfonylureas, and the risk was even higher, 1.8% in insulin. So we know that from the UKPDS that the tighter blood glucose control does improve the microvascular complications, but it was not known whether we keep controlling the blood sugar control, if we keep the blood sugar tight, whether that can reflect in a better macrovascular component. And that's why the 3 further trials came into the picture, which is a Accord, Advance, and the VADT trial. So if you look at the UKPDS, this is a slide to summarize it. We'll go every trial more in detail. So UKPDS did show the reduction in the microvascular complications. Macrovascular complications, immediately it didn't show any reduction, but obviously when they did the analysis 10 years, 20 years afterward, they show there was to a certain extent reduction in the macrovascular complications. Again, the mortality, there is not much change. The Accord trial was a quite eye-opener in a type 2 diabetes populations. And again, it was a very large trial, which was done in 10,000 populations. Um, these are the patients who has history of cardiovascular events and significant cardiovascular risk factors. And this was originally, it was supposed to run for 5 years, but again, it was halted at 3.5 years because of a significant mortality. So what they have seen there is that there was an all-cause mortality of 22% and 35% in the intensive group mortality. Now, the reason there is a one hypothesis for increasing mortality in this population because of the reduction in HbA1c was quite quick. So they dropped the HbA1c from 7.5% to 6.5% within a matter of 6 months. Now, in a clinical practice, I think it is very difficult to achieve. We don't do the similar reduction in HbA1c that faster. So that was one hypothesis why there was increasing mortality. So rapid reduction in HbA1c can cause other problems like exacerbations of retinopathy, peripheral neuropathy. There are some case reports in literature, and the similar way, this also reflects to the Accord trial as well. What is more interesting in this trial, if you look here, is the risk of death, relative of death of severe hypoglycemia was higher in the standard arm as compared to the intensive arm. And the one reason could be because whether there is when the patient recurrent hypoglycemic episodes, whether there is a blunted sympathoadrenal response, and that's whether it acts as a protective mechanism, we don't know. And that's why there is quite a discrepancy. So we're expecting the death rate will be higher in the intensive arm, but that was not seen in the Accord trial. Again, very important finding from the Accord trial was that it has identified the certain populations who has increased comorbidities and which act as a risk marker. So the hypoglycemia in those populations acts as more like a risk factor rather than the risk marker. And which of these populations? So from the Accord, most of them, they were African American women, older patients, again, the patients who has HbA1c or longer duration of diabetes. And what is a common theme we have seen in Accord and Advanced was that the patients who has got higher albumin to creatinine ratio, these populations was increasingly disadvantaged by the hypoglycemia. We look at this was a VADT trial, again, Veteran Affairs trial, which was carried out in relatively smaller population of type 2 diabetes, nearly 1,700, nearly 1,800 populations. Again, it has shown there was quite increasing risk of severe hypoglycemia in the intensive treatment group, but there was no significant difference of the cardiovascular event between the two treatment groups in this. What we learned from the VADT trial was that there was if the patient has a severe hypoglycemia in the previous 3 months, then the mortality, cardiovascular mortality was quite significantly high. So the relative risk ratio was 3.7. And as we discussed earlier, it has also shown there are certain predictors of hypoglycemia as we've seen in the Accord trial and Advanced trial, which includes patients who has previous cardiovascular event or patients who are on insulin or patients who has got a high albumin creatinine ratios. The Advanced study, which has got more or less the same populations as the Accord trial, it again show quite increasing risk of the hypoglycemia in the intensive arm, but we couldn't establish association between hypo and cardiovascular mortality. And that could be because the blood sugar drop achieved was quite over the period of the time. So the gradual drop in HbA1c achieved in Advanced study, that could be the reason for reduced cardiovascular mortality. Other possibility or other hypothesis was that very small number of patients, nearly less than 3%, who had a severe hypoglycemia. But what we have learned from the Advanced study was that still, if you look at the microvascular events or microvascular outcome, the risk was threefold higher. And when we look at the microvascular outcome, it remains significantly high with twofold higher risk. It has also shown that there are certain vulnerable patients, which we have seen in the Accord as well as the VADT trial, which can get a recurrent hypoglycemia. I'll quickly look at the origin trial where they look at the basal insulin, insulin glargine versus standard glycemic care. But again, there was not much association between non-severe hypoglycemia and cardiovascular outcome. Again, large number of populations, nearly 12,000 populations, patients with the dysglycemia was involved. And what they did in the origin trial, they tried to achieve the fasting blood glucose less than 5.3 as compared to the standard care. They have seen that the increased cardiovascular risk in the patients who has got a dysglycemia, but again, we couldn't see the clear association between the two. So what we are learning, what is evident so far is that the causal relationship between hypoglycemia and mortality or hypoglycemia and death, it is difficult to establish, but we do see that constant association from the epidemiological studies as well as from the observational studies and cardiovascular trials as well. The LEADER trial was the first where they used the liraglutide, the GLP-1, to reduce risk of primary MS events. They have seen the reduction in the cardiovascular events with the liraglutide. And again, it was independent of lower incidence of severe hypoglycemia. So it has shown the benefit in the populations, but no risk of severe hypoglycemia, which was obviously a good findings. Carolina trial wasn't much helpful in terms of the looking at the hypoglycemia association. So those were the studies which we have seen, mostly in the outpatient settings. If we look at the inpatient settings, the picture is a little bit different, and that's why it is conflicting, can confuse the clinicians to look at which one of them is actually reflecting the true picture. So if we look at the Digamis trial, which was published, the first one where they looked at insulin glucose infusion in acute myocardial infarction patient, and this has shown the improved long-term survival. But if we look at subsequently, 8 years after that, the Digami 2 came into the, Digami 2 was published by Malmberg, the same author who published the Digami trial. And that has shown there is didn't confirm that the insulin infusion which was used in the Digami, it didn't confirm the superiority. But they didn't see the association between the hypoglycemia and the future morbidity and mortality. So it was very difficult to draw any causal relationships from these two studies. Subsequently, there was a nice sugars trial. Again, this was published in NEJM in 2009, where they seen that the intensive blood glucose control in intensive care settings did increase the hypoglycemia, did increase the mortality in the intensive care setting. Other point to note from this study was that the patients who were not on insulin, and if they develop the hypoglycemia, then that is also considered as a risk factor. So it looks like more like a marker of vulnerability in these populations, which predicts the future outcome. Now, what do we learn from outside the cardiovascular system? So if you look at this, another study, which is from the, this was carried out in a stroke patients, and where they achieved the tight control of the blood glucose. Again, we couldn't establish any clear benefit in these populations. The similar trial was carried out in a sepsis patients. Quite a large number of patients were involved, nearly 16,000. And this had shown the higher incidence of hypoglycemia in the patients who were treated intensively. So achieving the blood glucose level or chasing the blood glucose level doesn't work in the patient's favor. It might make the clinicians happy, but there is a background, there is always a damage happening in the background, which we all should be aware of. And this is the last slide where we look at the 16,000 patients published in 2008. Again, very large trial where they have found that not only the hypoglycemia, but the fluctuations in the blood sugars. So when there is a incremental rise in the blood sugars above 120 milligram per deciliter or less than 70 milligram per deciliter, that can also have impact on the mortality. So there is a clear association, J-shaped association, which was seen from this study. So most of the studies which were done, they were mostly in a type 2 diabetes populations. And subsequently, the thought was whether the similar risk of hypoglycemia exists in the type 1 diabetes populations. And that's why this was the EuroDiab study, which was carried on. Again, the EuroDiab study was mostly in the type 1 diabetes populations. This was to reflect that the severe hypoglycemia was noticed in the DCCT, but most evidence from type 2 diabetes. So let's start the trial in type 1 diabetes populations, but there was no association was found between severe hypoglycemia and cardiovascular diabetes in a type 1 diabetes populations. So there is a conflicting evidence what we can see from all these trials. And what causes the conflicting evidence, what causes all the confusion is because the data or the evidence exists differently for type 1 and type 2. And again, the population which was selected was different as well. Why there was a difference between inpatient and outpatient settings, we can say that obviously in inpatient settings, the staff who is dealing with the hypoglycemia, they are more trained. The patient gets immediate attention. Sometimes you don't see the documentation of this hypoglycemia. So always there is underestimation of the hypoglycemia, I feel, from this, which is evident from all these trials. But what is more alarming is that if you look at the time from first hypoglycemia to cardiovascular event, it was seen about 1.5 years in both type of the diabetes. And if we look at the median time from first episode of hypoglycemia to death, that also remains about 1.1 years in type 1 and relatively less, 0.8 years in type 2. But I feel that is more like underestimation rather than the true picture. Let's move to the next slide. This was published about 10 years ago in Diabetes Care by D'Souza, and this shows you this gives you an overview of what underlying problem is in the diabetes populations, why the hypoglycemia is causing so much of damage. And as you can see here, it is a multifactorial damage. It is seen because of various mechanisms coming into the picture. Most prominent one is a sympathoadrenal response. And then endothelial dysfunctions, blood coagulation abnormalities, and we'll look at this more in detail. So sympathoadrenal response, as we all are aware, whenever there is a hypoglycemia, the blood sugar, as the blood sugar drops, there is a release of catecholamine from the adrenal gland, and this increases the myocardial contractility, increases the workload, and increases the oxygen demand from the myocardium. Now, if you look at the blood supply to the heart, most of the blood supply to the heart, it occurs in the diastole. So whenever there is a diastole, that time the myocardium gets vascularized and gets perfused. So if that diastole is affected in hypoglycemia, then obviously there is a less blood supply to the myocardium, and which can cause the ischemia and which can precipitate the subsequent events. Again, the blood vessels which are atherosclerotic, whenever there is increased oxygen demand, these blood vessels do not dilate, and obviously there is a mismatch between the demand and the supply. And there were numerous studies which were done to look at the electrophysiological abnormalities in these populations, which has shown the significant lengthening of the QT interval, increased repolarization, and this is probably the precipitant for the cardiac arrhythmias. Again, changes in the PR interval or ST segments has been also been seen, which causes ventricular tachycardia and the sudden death. What is interesting to note here is that the hypokalemia, so the hypokalemia, whether it is because of the shift of potassium across the cell during the treatment with insulin, that always accompanies the hypoglycemia, and it increases the cardiac repolarization abnormalities in these populations. Now, the role of inflammation is always been debated. There are various studies where they look at certain inflammatory markers. Some of the studies, they look at CRPs, interleukins, tumor necrosis factor, but not in all the studies. So there is a very difficult to draw the conclusion because the increase in markers we don't see always, and whenever we have seen that, whether it doesn't mean that it is a reflection of damage, I think we don't have much evidence around it. But what we have seen is that the hypoglycemia and the epinephrine release, which occurs subsequently, it can affect the platelet activation. It can also cause increasing blood coagulability, thrombosis, and which has also seen probably increasing mortality in the populations as well. And if we look back to the Accord trial or VADT trial, which we have discussed earlier, there is a vessel wall stiffness was seen, and probably that was because of the hypoglycemia. So I'm sure most of you treat the patients who are from the various backgrounds. So the patients who are elderly populations, patients who are, I mean, I myself don't get involved much into the children, apart from transitional care where they have, when they get 18 years, they move to the adult services. That's the only time my involvement. I don't treat the children, but if we look at the elderly populations, which I come across more often, or I come across the pregnant populations in my antenatal clinics, this is a very important area where we have to pay attention urgently. That's what I feel. So if we look at the elderly populations, first of all, the elderly populations, unfortunately, these are over-treatment is very common in these populations. They are mostly on sulfonamidase and insulin. Most of them, some of them are reluctant to go on the insulin, or they remain on the insulin despite being a lot of comorbidities, and that can also increase the risk of hypoglycemia. Again, when they grow older, there is a reduction in the cognitive function in certain populations, and because of the comorbidities, cognitive functions, and then depletion in the renal functions, again, excretion of insulin get hampered, which can precipitate the hypoglycemia. If we look at the pregnancy settings, now it has been shown by the studies that hypoglycemia is pretty common in a pregnancy settings, which is happen mostly in the first trimester, and that's because of associated morning sickness, which we see in the pregnant populations. Some of these populations are either type 2 diabetes who are premorbidly on insulin, or some of them are type 1 diabetes who are on basal bolus regime or various different modalities of the insulin delivery systems. Now, it has been also evident that the myocardial infarction is about 3 to 5 times more common if they have got a pre-existing diabetes and pregnancy. So this is something we should be all aware about. And we can always argue whether the relaxing the targets of blood sugars, is it good for these populations? Because we know that the tight control of the blood sugars in pregnancy, it will improve the fetal outcome. So the message from this is that we have to make every effort to maintain that normal glycemia and avoid the hypoglycemia. So that's why they need more frequent appointments, more frequent support, which we are lucky to have it in NHS to the diabetes specialist nurses or the midwives who can keep an eye on the blood sugars. And now during the pandemic, a lot of people we managed to get on the CGMs. A lot of our type 1 diabetes populations who can upload it on the cloud, and we can review those blood sugar readings and advise them over the phone. When it comes to the children and adolescent, obviously this is 2 younger populations who can develop any cardiovascular comorbidities. So the death in these populations, unfortunately, if at all it happens, it is because of the more like accidental death. So the seizure due to the hypoglycemia, or accident or drowning because of the hypoglycemia. And if we look at the hypo and hyper comparison, again, the diabetic ketoacidosis still tops the list. So the more common cause of the death in these populations in DKA rather than the hypoglycemia. It was seen in what we call as a dead in bed syndrome, which was mostly because of the cardiac arrhythmias, which is precipitants of the nocturnal, which is precipitants of the nocturnal hypoglycemia. And this is where we have to be all vigilant. Other factors to realize in this population is type 1 diabetes populations, if they have got impaired hypo awareness, then they are more at risk of further hypoglycemia, and then blunting of the sympathetic response, which can cause, again, more impaired awareness. So they are in that vicious cycle, and that's where the CGM does the wonderful job to understand this pattern. Now, if we look, whenever there is hypoglycemia occur, the next question we have to ask ourselves is that whatever the damage is happening, is it happening only at that particular time, or does the damage last longer? And this has been seen in various studies that it creates a certain atmosphere, a certain intravascular milieu, which can actually increases this thrombotic event even in the future. And as I mentioned in the previous trial, where the ACCORD trial, where there was an increasing cardiovascular risk or mortality in the standard arm, which debates whether the repeated repeated hypoglycemia and sympathotrenal response blunting, whether it is a protective mechanism. So we don't know about that. But what we have learned is that the hypoglycemia definitely causes cardiac repolarization, which can cause cardiovascular, which can cause cardiac arrhythmias, and this is a more common cause for the death. So what is the role of the other hormones apart from the catecholamines? This is nice paper which was published in 2012, where they look at counter-regulatory response in a hypoglycemia, and this has shown there is a plasma aldosterone. So there is activation of renin-angiotensin system, which produce more and more aldosterone, and this can stimulate the mineralocorticoid receptors. And again, the beta-adrenergic sensitivity, that also goes down as there is a sympathadrenal response gets blunted over the period of time. What is interesting to note here is that if we look at the cytokine selective release response, as I mentioned earlier, it is not consistently seen in all the studies. And whether that has got role to play and to what extent the role to play, that's something the area of research in the future. When these patients treat the hypoglycemia, as you can see in the clinical practice, is that especially when the Libre 1 came into the clinical practice, the patient will treat their hypoglycemia and then they will scan it. So obviously the scanning blood sugars is not showing you the real picture. So when they treat the hypoglycemia with 15 grams of sugar and check the blood sugar in 15 minutes, according to the guidelines, the CGM will still show the blood sugar is on the lower side. So they tend to have extra carbs, and then they will have this big spike in the blood sugars. So that hypoglycemia and hyperglycemia, hypoglycemia and hypoglycemia, what we see in the clinical practice, it is also not very good for these patients. So this can have more detrimental effect in the endothelial function, and this can activate thrombosis, which we all should be aware about. Now, this is a rather very sad slide, I would say. This was, CGM was treated in young type 1 diabetes populations. Most of you must have come across this before. So this was a 23-year-old gentleman who had a type 1 diabetes and on a hypoglycemia awareness. He was prone to have seizures, and that's why they put CGM on him. And also he was having cardiac monitoring at the same time. That's why we could capture that on his CGM. And as you can see, 8 o'clock when his blood sugars started going up. So you can see that there is a straight spike in the blood sugars. That's probably because of the increasing carbohydrate or mismatch of the carbohydrate and the insulin. And then he had repeated bolus of the short-acting insulin. So he had a lot of short-acting insulin within a small, short span of the time. And what it has resulted is that this has caused the stacking of the insulin, what we have to always should be aware about. And this stacking of insulin called hypoglycemia. So when he went to the bed after midnight, his blood sugars went right down, and then it keep going down. And obviously because of the hypoglycemia unawareness, he couldn't recognize that, and this has resulted into the death. This patient had subsequent autopsy, which didn't reveal any obvious cause apart from likely explanation was a cardiac arrhythmia, because the autopsy didn't show any organ damage as such. As also you can see, there are 2 spikes. So there was a counter-regulatory hormone response did come into the picture, but it was not sufficient enough to wake him up from the sleep. So dead in bed syndrome, which is seen in young populations with type 1 diabetes, and it is 10 times increase in risk in young populations. CGM is very excellent in demonstrating that, the trace. So when we look at the CGM trace, other things to be aware about, if the patient is putting the CGM on their arm and when they sleep, on that side, there is something called as a pressure effect. We can utilize the flat line as well. So it's very difficult to differentiate whether it is a true hypoglycemia or whether it is because of the pressure effect that your sensor is pressing against the pillow or the way you are sleeping. And what I learned from last talk by Professor Rajan in Leeds is if you have a wavy pattern in that CGM, that is more like a hypoglycemia. If you see the straight flat line, that means it is because of the pressure effect rather than the true hypoglycemia. And again, this experimentally induced hypoglycemia was seen in type 1 and type 2 diabetes patients. As we earlier discussed, this has got a pro-arrhythmogenic potentials and can cause prolongation of QT interval. This was a paper published quite a long time ago in 1997, where they compared the QT interval between populations with euglycemia and the population which was hypoglycemia. And it was very clear that the QT interval, which was 456 milliseconds in the patients with a normal blood sugar, has actually got prolonged to 610 milliseconds when they were in a hypoglycemia. This is a study where they have seen the increasing bradycardia in the populations, especially in time. So when there is a sympathetic system calms down, when there is a sympathetic system is not active as it is during the daytime, then obviously the response to the hypoglycemia is not pronounced, and this can precipitate the bradycardia as well, and which is another comorbid you should be aware about. If you see the topmost slide on your right, the blue line which is showing that the blood sugars is, whenever there is a blood sugars going down from the midnight onwards, the QT interval keep prolonging subsequently. And the T wave changes also is very evident in this same slide. So we'll quickly touch base to the awareness of hypoglycemia. There are various tools which we can use in a type 1 diabetes. Obviously, the type 2 diabetes, it's more time because we need to have a good history. We need to pay attention to their diet and food diary if they can bring along with them, or if there are any associated risk factors, or if there is a change in their weight, because it can also reduce the insulin requirement. So it's a comprehensive assessment what we need rather than paying attention to, rather than the tick box exercise, I would say. If we look at, there was a paper published a few years ago which looked at the number of factors which can affect the blood sugars, and there were about 42 factors. So I always feel that the type diabetes populations in a clinic, they need more time than your endocrine patients, because endocrinology is more like maths, while diabetes is more like holistic management. You have to look at a lot of other issues. And this is more evident when you look at these patients for the hypoglycemia. Now, what is more important is to ask these populations about their how good they are at picking up the hypoglycemia. This is very common. So we make every effort in our clinical practice to ask these patients about their awareness of hypoglycemia. So most common method which you can do in a clinical practice is a GOLD method, which is a 7-point scale, and you have to ask the patient, can you pick up your hypoglycemia when it drops? And how can you do it all the time, or can you do it sometime, or you are not aware of it at all? And then you can grade them from the scale of 1 to 7. If you find out that it is a more than 4 or equal to 4, that means there is a risk of severe hypoglycemia and 6-fold if they are type 1 diabetes, or it is even higher, up to 17-fold if they are a type 2 diabetes. You can also use other method which I have not used myself, which is called as a Penderson-Gergard method. But I feel this is not the right way to look at the hypoglycemia estimation, because it is a more simplistic approach to something more complex as a hypoglycemia, where they ask the patient, can you feel when your blood drops? And if the patient says always, that means they're aware. And if they answer anything different, then they're hypo-unaware. And this tends to overestimate the prevalence of the hypoglycemia by this method. There are various other methods which was used. One of them is a Clark method. Again, if you score them, and if their score on the Clark method is more than 4, also shows a quite significant risk of severe hypoglycemia, up to sixfold in a type 1 diabetes populations. This is a very good one from the Daphne hypoglycemia awareness, and there is a lot of evidence around this rating. So what we do here is that we ask the patients, when your blood sugar drops less than 3, can you make it out, or you make out when your blood sugar is more than 3 or equal to 3. So if they can pick up the blood sugars, if they get the symptoms of hypoglycemia when the blood sugar is more than 3, that means they're hypo-aware, otherwise they're hypo-unaware. And this was subsequently published in Diabetes Care in 2012 to look at efficacy of this rating. So relatively small studies, only 500 populations, 500 patients roughly, but the 60% of these populations was hypo-aware and 40% had impaired awareness. Now, the rate when these populations had a follow-up subsequently, then they have noticed that the severe hypoglycemia was less in both the groups. But not only that, they have also seen that 43% of the populations who had impaired awareness prior to the study, they have actually regained their awareness as well. So this was a very good one. If we can achieve that and resonates that in our day-to-day clinical practice, this would be good for our patients. And as Dr. Chawla has mentioned earlier, there is international consensus guidelines when we look at the CGM data, when we look at the time in range. And if the time in range is more than 70%, that's a reflection of HbA1c of 7%. And there is a growing evidence that this can reduce the future complications because of the diabetes. It is again important how we put this. So I have seen the two extremes, where the younger populations who are trying to achieve this time in range up to 90% or 95%. So they look at the percentage or percentage as a reward, which we should be very careful about, because if whenever they try to achieve that, if it is coming with the expense of hypoglycemia, then that's alarming. So we have to make sure that they are not having good time in range with the expense of hypoglycemia. Hyperglycemia, we don't see that often, but we always see the established link when they try to chase the numbers between the hypoglycemia and the time in range. And again, the counseling is very important in this population. So I always tell them that we don't want you to be 100% all the time, which is not possible, which is not realistic. So what you can do is, if you do 16 hours a day, roughly, or 70% of the time, if you maintain the blood sugars between that 3.9 to 10 millimoles, then that's a big achievement for them. So we'll try to improve them from whatever the percentage they have time in range towards the 70% goal. And what I have noticed in the clinical practice is that there is always a risk of hypo and hyper. So when there is a time above the range is high and time below the range is low, time below the range is also high, what we see is that they are having a lot of hyperglycemia because of mismatch in the carbohydrate and insulin. And then what they do is that to correct that hyperglycemia, they have too much insulin, stacking of insulin, which can cause recurrent hypoglycemia subsequently. So that's to educate them better. Other most common missed things was like something like insulin injection sites. Obviously, during the pandemic time, we were hardly able to see our patients, and that has we teach the patients, or we taught the patients in the past how to look at their insulin injection sites, or if there is a change in weight. So it is more a detailed approach you need to do, and it is very challenging on the telephone consultation, I believe, since that time. There are various questionnaires developed. There's a lot of research on International Hypoglycemia Study Group, very good website where you can see there are patient education materials or clinician material. Recently, the Academy, which was developed by the along with looking at the CGM data. And some of the younger populations who are type 1 diabetes, I usually direct them to look at how they can interpret the CGM themselves and how they can use that in a clinical practice. So better patient education is the key here. Structure education, interestingly, the first one was developed in a German, which was a DTTP program, and then it was translated into the English, which was used in the Daphne, which is a dose adjustment for normal eating, what we use in the UK for type 1 diabetes populations. Again, the Daphne has got various versions, which was adapted to the local populations. So where I work in the York Teaching Hospital at the moment, we are using our own version. And similarly, it was adapted in the different hospitals. The one which was used by Tayside insulin management course, this has shown the hypo awareness improvement about 25% of the participants. Again, the small study, but it was a very good effect in the patient populations. Bertie, it was done in the down south in the UK, Bournemouth, which was intensive education program for the type 1 diabetes. And if we can't fit them for this proper structural education program, then even the quick catch up with the diabetes specialist nurses or the dietitian, that also helps them to educate themselves. And there are various blood awareness training. This is my last slide where we look at the various other ways we can combat the hypoglycemia. So if there are recurrent hypoglycemia without any obvious reason and causing the suboptimal blood sugar control as well, various options we can try, either the insulin pump, cesium, as we always discuss. There are new Medtronic pumps, threshold suspend pump, where wherever the moment the blood sugars starts plummeting, actually the can sense it and it suspends the insulin for next few hours or a couple of hours. And after that, it keep monitoring the blood sugars. Your sensor can talk to the pump, and whenever the blood sugar starts going up, then it starts pumping the insulin again. So this is a very smart technology which has been used by the Medtronic company. Again, the hybrid closed loop, it itself is a very vast topic. So we can talk about for many hours on the hybrid closed loop, which is currently more in news, you must have heard about. And the islet transplantation, which is used in the Fewer Center. I have not involved myself into that. That's another option.